Good afternoon, and welcome to Improving User Satisfaction, Empowering Innovation, and Facilitating Governance by Increasing Self-Service Data Management, a Health System CIO production sponsored by Data Dynamics. Just a little housekeeping before we get started. My name is Anthony Gurrera. I'm the founder and editor-in-chief of HealthsystemCIO, and I'll be your moderator today. We're looking forward to your questions or comments. You could send them in at any time in the Q&A box, and we'll address them later in the program. Just so you see how we're going to spend our time, first we're going to go about 35 to 40 minutes on our main panel discussion featuring Dr. Shafiq Rab, EVP, Chief Digital Officer and Systems CIO with Tufts Medicine, Justin Coran, Chief Analytics Officer with Renown Health, and Piyush Mehta, CEO with Data Dynamics. And then we will have our Q&A. So let's jump right in. Lots of important stuff to talk about. And we'll start with you, Dr. Rob. Can you give us an overview of your organization and your role?
I have the unique privilege of working for Tufts Medicine. Tufts Medicine is in the Commonwealth of Massachusetts. We are we have the distinguished honor of having the largest number of heart transplants. So we are an academic medical center. We are a medical school. At the same time, we also have a couple of community hospitals. At the same time, we also are lucky enough to serve hospice, home health care, and a mental health place. So we have a very unique way of working for the community, and we're trying to bring the cost of care down. And as a health system, we're trying to break down the cost of health so that we can be more productive, better. We also take care of a lot of veterans in our area. So as an institution, we are the place where everybody goes, and we try to take care of them. We are very proud of that.
All right, excellent. Very good. Thank you. Justin?
Yes, hello. My name is Justin Coran, and I'm the Chief Analytics Officer of Renown Health. I'm also an adjunct professor at the University of Nevada, Reno, in the medical school. And I work very closely with our Chief Information Officer, Chuck Podesta, at Renown Health. He's a critical thought leader for me. Renown Health overall, we're more of a regional health system based out of Reno, Nevada. We actually serve over 1 million patients who live in a 100,000 square mile market area in northern Nevada, northeastern California, and then also in the Lake Tahoe region and area. Overall, Renown, we have about over 7,300 employees. We are affiliated with the med school, but what's one neat fact about us is our affiliation with the med school and our journey to become an academic medical center is only about 3 to 4 years old. So it's fairly new, and we're very much in our transformation process of being able to become an academic medical center, be more integrated with academics, research operations. And then this goes in great with today's conversation of how do you facilitate data analytics and management across even 2 different institutions to achieve some of the key strategic focuses. So excited to have this conversation today. Thank you very much for the invitation.
You're welcome, Justin. Thank you. Piyush?
Thanks, Anthony. It's great to be on a panel with 2 esteemed and knowledgeable people such as Dr. Rob and Justin. My name is Piyush Mehta. I'm founder, CEO of Data Dynamics. We at Data Dynamics are a company focused on driving data democratization by making enterprises, including healthcare systems, better custodians of their data and empowering the individuals who own the data to actually manage and have control and say over their data. The company is now 13 years old. We are in 28 of the Fortune 100, or have served 28 of the Fortune 100, including specifically around verticals in financial services, energy, and healthcare. Look forward to the conversation.
All right, excellent. First question, Dr. Rob, we'll start with you. How does self-service data management align with your health system's broader strategic priorities, such as improving patient outcomes or achieving operational efficiency?
So Anthony, my friend, and Justin and Piyush, it's a dream for everybody to get to that state of self-service. With the world as has talked a lot about AI and the new use cases coming in, and with generative AI being forefront, and also our electronic health records, they also have started adding ambient and generative AI and other things to help us understand the health system where we are. But we are not there yet. So the question that you are asking is that, yes, we have apps, we have APIs. For the patient, they can look up, ask questions, but there are multiple types of data. So as you will go forward in this discussion, there are financial data. There are data that allows you to discuss what are the new ways of doing business development. Then there are clinical data. Then there are administrative data. And then there are managerial data that people do on a day-to-day basis. Finally, there is research data and clinical data that is used for research, or non-clinical data that is used for the purpose of understanding it. But the key here is that all of this is great. But what I like what Piyush talked about in the beginning is the democratization of data. People talk about democratization of technology, but democratization of data is very important. And just to add three sentences, beyond, behind that is governance. Behind that is ontology and semantics. Behind that is definition. Behind that is alignment. Behind that is the vision. So if this was so simple, we would not call it complex, even though all of us, our desire is that we can get the answer in a lickety split, which is a technical term.
All right, very good. We'll certainly dig in more there. Justin.
Yeah, overall, being able to service data to the masses in a health system is a journey. And it's one of those that ends up through iteration, and it requires a lot of coordination. It requires governance. It requires training and education. It also requires having what I'll call a very strong data foundation. So that means that you can define your metrics and your information coming out of your data environment and communicate that downstream to anyone that might be using your self-service data management tools. One thing that I've observed, even in the last couple of years, that is a business challenge that we're currently trying to solve, is you can provide as much data as requested to the user. And what I end up seeing happen, let's call it 9 out of 10 times, is you'll get them 90% of the data that they need to ask most business questions of their area of operations, whether that's clinical or administrative, but it doesn't answer all of them. And it ends up with this back and forth iteration where they'll look at a piece of data, maybe it's trended, and then they have follow-up questions after that. And the piece of reporting they might be looking at does not allow them to answer follow-up questions or potentially dig into more information to create business strategy and actually have change in effect. And so that becomes a weakness of the self-service data, is how do you provide self-service analytics in a way that can almost answer all of the relevant clinical and business questions? And I'm not sure any health system has yet solved that business challenge completely. And this is where I'm also excited about artificial intelligence. My view of artificial intelligence is its role in healthcare in the future is a force multiplier. Is can we potentially use artificial intelligence systems to fulfill that 10% gap? Could you ask your GAI tool to provide the answer to your business question once you deliver a certain level of really well delivered self-service analytics with cultivated foundational data? And I also want to reemphasize everything that Dr. Rab shared is also critical in order to deliver a really clean and workable solution in self-service analytics. So I am hopeful that AI might be able to solve some of those business challenges, but that's the key thing that I deal with every single day, that for every great report or every great tool we put in a physician's hands or administrator's hands, it still can't answer all of their business questions, requiring a cycle of back and forth between analytic professionals and the business end users.
Very good. Excellent, excellent. We'll dig into that more as well. Piyush, what are your thoughts on what you've heard so far?
So I would say that when you think about healthcare systems, there are two key initiatives that they would all have. One is to have proactive identification, to have preventive outcomes. Second is to avoid recurrence. So in order to do that, it's contrary in a way or counterintuitive from a healthcare standpoint to also achieve their P&L goals, which is, hey, how do I drive profitability if I achieve nirvana for getting the best patient outcome? But that being said, the first step in that is to make sure that in order to do this self-service and to drive that, you need to understand what you have in terms of patient records, in terms of insurance records, in terms of machine and operational information, HR information, and then to understand who you want to grant access, how you want to grant access, and then what does that self-service really mean? Does self-service mean their ability to read it and just use it for certain cases? In the world of AI, does it mean to allow models to use it? Does it mean doctors to use it to drive proactive management? So again, multitude of different avenues, but what I will say is that if you think about the most successful healthcare providers, they are going to be able to leverage data that is properly classified, properly governed, protecting the privacy of their patients, and ensuring the best healthcare outcome for which they would get rewarded, whether it's through insurers or the federal government.
All right, very good. We'll keep it going here. We'll go to the next question. Justin, we're going to start with you. What are the most significant challenges you've faced in enabling self-service data access while maintaining centralized governance, and how have you addressed them?
Sure. And so there's a couple different challenges there. One of the first one is making sure that everybody is aligned that's going to touch the data on the definitions, the foundation, and how that data is managed within our environment. So for example, one weakness that I saw when I first came to Renown Health, and something that we worked through fairly quickly, is having multiple variations of a definition of a measure, right? And that's something that then starts having different decisions and impacts on decisions. So you want to unite. So for example, readmission rate. When is it appropriate to use a readmission rate definition from a payer versus potentially from CMS and the federal government versus an institutional definition? And some of that needs to be locked down so that when you do service data in a self-service approach, everyone's interpreting that data and the meaning of that data the same way. And so that's one. The other biggest challenge that we have, being kind of trying to build out the academic research mission and partnering with UNR, is how do we start sharing our sensitive data institutionally to be able to activate either a research mission or an academic mission? That's been something that we have spent a lot of time on in the last year, and creating the use cases of when is it appropriate to just have, let's say, a de-identified research data set, and hopefully that solves, a lot of research questions for the masses, but that may not solve all of it. When is it appropriate that you can use identifiers or certain types of sensitive data in the context of scientific research? And so we're working through a lot of that process institutionally. And that's probably one of our biggest challenges right now, is staying within compliance, making sure we're being ethical, and that we can service this to be able to not just keep operations going, but then also start building out that research academic side that the company is starting to move towards.
All right, very good. Dr. Rab.
I think Justin has very nicely explained in detail. I can add a little bit, just except for all of these things. Number one thing, I call it digital trust. People call it just trust. Second thing, what I figure out is that even though you do that, down the line, you should have data curators and data sponsors, you can call them, validators, you call them, because what's happening is that if there is no trust and the information that you have done and has not been validated, your boat is already sunk. So that part, once you fix it, then you have to fix the challenges that you're talking about. Who gets access to what? And like, I should not have access to the payroll. That's not right. I should not have access to the entire pharmacy, where the doors are. I should not have that. So that risk stratification, that knowledge also is important as you are building this self-service, because ultimately you will ask somebody to do machine learning, or you will ask somebody, tools are easy, technology is easy, AI is, I should not say is easy, but it's there and it can do its job. But Problem is that you can't have a mistake in it. But if you have a mistake in it, then you have to have a trusted correction process. That means everybody knows that if something is not right, then Justin and his team has got a thing there that can be done. Or if you are using Mr. Mehta's company, then they will fix it. That takes the longest time. And as we are doing this, we also have to understand that we have to bring disparate data. That means you have the HR data, you have the financial data, we have the research data. They all reside in different places and there are different stewards of it. So we got to have a coalition of that. And to understand that the identity one place changes, it can change something else somewhere else. That complex understanding how the data flows, how it affects, has also need to be democratized. That means you just can't say, that means, in other words, I'm saying transparency, accountability, but with full understanding that we are all in it together. That is the hardest part that has taken me and my institution, other institutions, to actually be useful. You know what I'm saying? Because until unless we provide that level of clarity, we can't say that the data is right.
Piyush, what are your thoughts?
I think Justin and Dr. Rob have hit some key points that are very valid. What I will say is, to add to Dr. Rob's comments, management of data and technology is very siloed in all organizations. So you have CISOs that look at it from a security standpoint. You have CDOs that are looking at it from a lineage and classification. You have CIOs that are looking at it from an infra. You have lines of business, or you have, let's say, medical departments that each has their own view. Unless you can centralize that they're all looking at through, and I hate the cliche, but the same single pane of glass. The problem is each looks at it with their own quote unquote tools and their own siloed software stacks. Until you can standardize that to say, okay, I'm going to analyze this in terms of the discovery through a single pane of glass, but then customize the views based on each of these profiles or personas, that then provides you a level playing field. And without that level playing field, you're each kind of playing in your own sandbox and not knowing what the size and scope of that sandbox is at an aggregate. So by having a single consistent way to do discovery, to do classification, where the terminology is similar or same actually across the board, is a concrete and important first step. And that usually is not the case in almost all customers that we at least talk to today. Because once you do that, then governance, privacy, and enablement become a byproduct, because now you have a consistent layer and now each one's just setting their own policies based on their needs, their requirements to drive an outcome.
I think, Mr. Mehta, Piyush, you have said it very nicely, brother. And Mr. Coran, you also have done a phenomenal job. I can only add two things after listening to you, is that, and from my previous experience, that if it's an operational led, clinically led, supported by the chief AI officer or the chief analytic officer, and on the back end by the infrastructure person from the IT that makes it better, quicker, and brings the platform, then it goes a long way because it builds that groove. And at the same time, when picking technology, we should pick a technology that can easily be used by them. Because the idea behind is the following. We want this experience to be meaningful and pleasurable. That's why in our country we're having a problem on giving up TikTok, because it's the use has to become that. It cannot be just for use. It has to be really pleasurable and meaningful. That is the true essence of a self-service data.
Yeah,
Uh,
let's talk about that a little more, Justin. This idea of it having to be pleasurable.
I love that idea. And I'll be honest, I think the fact that I think health systems have always been in a good place when it's come to reporting. Where I think the traditional answer is put as many reporting tools as you can in the hands of business users in order to solve data to the masses. And then we saw the after effect of that, where, okay, there's a certain number of reports that you can almost hit a critical mass at in a company, where when you hit more than that number of reports, it becomes an administrative burden, but it also becomes an avenue where you can start distrusting data. So for example, if you want to change the way a report functions because you don't like to consume the information in there, you're creating literally a completely net new report that could have the exact same information, and you keep increasing your data assets, which actually both increases cost on storage, it has other downstream unintended consequences, but it really creates administrative burden just trying to keep that information trustworthy, updated, and so forth. The evolution of, can you interact with a tool, have joy and meaningful use within your day, but then it also meet all of your key business questions and your day-to-day responsibilities, is really that gold standard. And I think that's what we're looking at for, is in the current reporting environment, does this truly meet the needs of the business users? Which also means, are they willing to look at that on a day-to-day basis? Because if they're not willing to look at it on a day-to-day basis and it provides critical information that could have a day-to-day impact, what can you do to that asset where you can gain that level of engagement across your enterprise to be able to have the behavior you're looking for? And if that's kind of like daily engagement with your reporting, then if you can make that enjoyable as part of their job, such as gamification or even in that design aesthetic, then I believe we need to look at that as a health system and a strategy going forward across the board of our reporting strategies.
Piyush, any thoughts on that? That idea of it being a
uh,
pleasurable experience?
I would define pleasurable in today's user environment as ease of use. At the end of the day, any application that you use, and I always refer to my team to Apple, the ease of the product's use drives adoption because by default, there is no instruction manual. And with things like generative AI, you're going to be able to present and give users the ability to have that type of experience. So instead of getting, let's say an MRI on a disc and not knowing what it means, and a radiology report that, unless you are medically prone or you're a doctor, you wouldn't understand. Having that simplified, easily explained, easily explainable is very key. And that's all about ease of use. And I think with technology, the way it's headed, you are going to get that across all aspects of the ecosystem, from operational use to internal use to patient use, as well as to the ecosystem, both from a pharmaceutical side that ties into healthcare, as well as the insurance and payee side.
All right, very good. Let's go to the next question. Um, Justin, let's start with you. How do you balance the competing priorities of enabling widespread data access for innovation while ensuring data privacy, security, and compliance?
So I may have a slightly different answer here just because of where Renown Health is in their journey, because this is very relevant to if you are really building out an academic medical center where the intention is to share data across institutions. Now you're no longer just providing data for healthcare operations, right? Where they're all covered entities and it's kind of simple within the hospital or within the health system. And so my biggest balance is trying to meet the needs without necessarily taking too much time to go through all of the political discussions to, let's say, have a full in-depth comprehensive data use agreement before any research can be done. So I'll provide an example. So how would I balance that out? Well, I knew there was an opportunity, because we're at the beginning of our journey, to provide a completely de-identified database of medical encounter data to the med school to be able to start doing basically self-service research, where you can access that data set to start answering research questions and go through the appropriate ethical and compliance, research process, IRB, and so forth. But now they have an overall data set where they can start doing that work. How that worked before is they would have to put in a request to the health system. They would have to wait for the health system to be able to have bandwidth to create a limited data set, and then be able to provide that limited data set in the appropriate way that IT security has advised to the researchers. And if you're trying to do that by the hundreds, you've gotten to the point where if you only got, let's say, a 12-person analytics team that could even provide that type of service, they can't handle it by the hundreds, let alone the thousands if you're trying to scale up like a full university's research mission, just even in the healthcare, nursing, public health space. So by providing that de-identified data set then provides us, the business side, longer to figure out the more complex areas of providing data, such as the identifying information or more sensitive data around claims or finances or HR information. And while you're doing that with leadership in the earlier stages of an academic healthcare journey, the researchers can now start working on that de-identified data set. And there's some really good national models out there of how to create that type of like a de-identified medical encounter data set. One of them is called like the OMOP model. It's an observation medical encounter model that's commonly used in health systems. So that's where we started around health. I started providing the de-identified data, both in-house for Renown, so Renown doctors that are Renown employed that want to do it, but then also to facilitate that part at the medical school, the health school, the nursing school at UNR. And then that really enables us the time to start working on the bigger business challenges around that question of the more sensitive pieces of data and what does that look like to provide access to that.
Excellent. Very good. Dr. Rob?
Yeah, Justin nailed it, man. And such a depth. Only a couple of things that little add is that you can provide data visiting. That means anybody who needs to access the data, instead of sending the data, they can come to your place and do whatever they have to do and just leave. So the data never leaves. That's one way of doing it. Uh, of course, all the things he said about data use, signing the BA, the NDA, and all the things that people have to do and how to protect all these necessary privacy and security and compliance. The rule of the thumb is that we start from the beginning, not the IT process, but the compliance process, the data privacy process, the security process, data using process. And other rule of the thumb is that we can't manage 1 million requests. We have not reached singularity yet. That means we have not become one with the artificial intelligence. So that means we have to say no to a couple of things. We can't say yes to all of the things. There is a bandwidth thing, and that comes through governance. And then there are criteria that says, for example, this will provide patient safety. If we do this, this will change the clinical outcome. Those are important stuff. Or this will give us 5 to 6x financial gain. So by doing that, all the things that Justin said, we can add that to it and go forward with it. But most important thing that in all of this is that one of the things that we are still trying to struggle with, that when the data leaves your institution, whether it is identified, de-identified in any format, do we follow it after that or not? Or is it only being used for that use case that we have talked about? Or they're using it for something else? That raises a very important question. That's why sometimes what people use, they use a third methodology, which is known as, which a company does it, that every researcher sends their data through an encrypted line to an encrypted box where all the data is analyzed, and then through the encryption, the result goes back. Nobody sees anybody's data, and data never leaves the place. So there are multiple ways of doing it, but I don't know the answer to that.
Piyush, do you know the answer to that?
I have a suggestion. I'm not sure if it's the final answer, but what we've seen and how we've helped customers with our software is really being able to, once you understand what data is out there and identify things that are either privacy related, HIPAA related in terms of regulation, or business sensitive in terms of some of the innovation that may have been done in terms of that content. You would actually redact that. You would you'd keep the original copy, create a second copy, redact that information. And usually that information makes up sub 5% of that data set. And now you're actually using the content of the data, which is actually where the meat and potatoes lie, where the AI models, as well as any other research that you're doing in terms of accessing and using that data, can be done much easier. So when it comes to that, what ends up happening is that original copy can either be air gapped or you put your necessary controls in terms of access. But now that secondary copy becomes of commercial value, because at the end of the day, you are going to see much more sharing of data, going back to Justin's point, in order to create better outcomes. And synthetic data just doesn't get you there, which means you do need actual records. If you need actual records, you have to protect privacy, which means removing the patient information or removing any other thing that would be identifiable in any sense. And when you think about the world of personalized medicine that's coming, when you think about the amount of genomic data and all the research that's being done in biotech, it leads to an inevitable problem that if you can't share it and you silo it, you will get limited outcome. And I see a future where you are going to see pharmaceutical companies share that information, and sharing will have commercial value to it. So it's not sharing purely altruistically, but you are going to see a wider, and when I say that, I don't mean just in the US. I mean at a global level. Today I'm talking to you guys from Abu Dhabi. Well, there's a Cleveland Clinic a few miles from here, Cleveland Clinic, Abu Dhabi. They're collecting a ton of information. Like them, there's so many institutions around the world that are popping up where you are going to have global access to information about patients. And if you do it right, you can actually use AI models to create tremendous knowledge base that has huge value as you move forward to help achieve the two outcomes I talked about: proactive identification of potential issues that may arise in patients, as well as avoiding recurrence.
And
All right. Go
I
ahead.
just want to add to that for
Go
a
ahead,
second,
Justin.
because I think it's critical the role of AI playing in that space here in the future. I do think that there is a role to play in order to be able to adjust for some of the trials and tribulations, but on just the having enough people to be able to serve some of our data operations, where AI, I think, is going to come in. I mentioned this earlier as a force multiplier, is to be able to do more of those functions at scale with just one person. So if we do need to share more data and we need to scrub it and we need to have a process afterwards to make sure that we can audit it, we know where that data is going, to make sure that there's absolutely no identifiers. So the engineering team might solve it, but then what is the go forward process to ensure that you can't re-identify the data? I think that's where AI is also going to play a role in helping us do that better and helping us be able to alleviate some of the staffing and effort around that to make it easier for an analytic team to be able to provide data and share it. The other thought I wanted to add is I think the provider and health systems have an incredible opportunity in this space. I do not foresee anywhere in the next 5 to 10 years a scenario where any major health system is sending all of their data to a third party, a Silicon Valley company, a tech company to do significant AI model training. I think that opportunity rests in the provider organizations, that if you bring talent in-house and you can start developing your own AI models and train and fine-tune those, it will be able to be customized. It will be able to meet the needs of your physician and clinical workforce, and you'll be able to use it in a way that a third party may not be able to anticipate for that provider company, at least in the next 5 to 10 years. That may change as we get down further in the line and different tools and different policies and regulations come into focus in 10 to 15 years from now. But providers have a critical opportunity right now because, like in my shop, theoretically, we have access to all the data. We could be doing that type of AI development if we had the expertise in-house and if that was aligned to some of our major operational enterprise objectives. But I think that's an opportunity for health systems that are ready to start taking that first step and doing in-house AI development.
Yeah, so some are doing it. Large language models are expensive. Small language models are manageable. You are correct on that. And to build more AI, you need bigger data centers. There are only 4 states that you can actually build those data centers to get a gigawatt of energy. So while we do that, that's a long term. In short term, small language models are good. But the sad part is this, which is that you need a large amount of data to have conclusions or to have ideas. Most of the clinical data lies in each institution. So we have to create a mechanism, either through the EHR or either through joint shaking hands, in which multiple institutions share their data about clinical outcomes in one place, where they all jointly go and do those models. because to make AI work, the more the data, the better the understanding of humanity. Because God has given us a very unique opportunity to look into the soul of humanity by using AI. But to do that, that cooperation level has to happen. Some electronic health records are lucky enough to have all the data of 20, 30, 40, 50, 70 institutions, and they can come to a conclusion very easily. Or like some people have developed uh, dermatology apps. Somebody comes into a ER and you just take a picture of it. They go back and look at all the pictures of those things, and they will say, this is a fungus or this is this. So those things are developing because in the world of radiology, those things are possible because it's a 0 or a 1. So some people have been successful in that, getting all the pictures. So, and the part that you said, Dr. Mr. Mehta, that you are in Abu Dhabi, that means it cannot only be national, it has to
Correct.
be international.
Exactly.
Because in the olden days we used to live in one place and nothing would happen, but now monkeypox easily comes from one part of the world
Correct.
to the other part of the world. So therefore infectious disease and all the knowledge that surrounds the entire world, we need to create that kind of a database, at least for certain things, with common hand and common way of looking at it for the greater good of humanity, so we can actually find cure for cancer and cure for other things. But we're not there, man. We just, but Justin, keep on thinking that way, man. You're young enough that maybe you will see it in your lifetime.
That's really what I'm hoping. I was like, the decisions we make today is going to influence us 10 to 15 years. I know I still, knock on wood, will still be in my career there. And so I still think, where do we need to go 10 to 15 years from now? And what requirements of think and business thinking do we need to do today to set us up for success then?
Yeah, very good. Dr. Rob, you talked about that concept of organizations getting together, and there is that entity that they put together a year or two ago called Truveta, and they've got about 10, 15 health systems that are, I think, sharing data for the purpose of clinical analysis and all that kind of thing. So, um, I guess they're working on that. Um, anyway, yeah, let's go to our next question. And Piyush, let's start with you. And I want your advice on this. The steps that a IT team has to take to transition from being a gatekeeper of data access to becoming an enabler of self-service for clinicians and other users. So what have you seen among your customers that works as they try and make that transition?
What's really important is IT is only an enabler, right? The IT doesn't actually have access to the data itself. It has access to the underlying infrastructure. The way the enablement can become better, and going back to Dr. Rob's initial comment of digital trust, is by actually creating an ease of access for those clinicians and the data owners to access the data that they've stored or that they've created, whether it's their applications or their end user data, and then to be able to act on it, but within the governance set by central policies. So you can't hang yourself. I can take the policy and I can implement it. I can view all my data, but any action is based on the policies that are centrally set. So I can't just take the data today of that I have and send it to, an AWS instance or to a buddy of mine. I would have to, the policy dictates what you can do, but the actual ability to view your own data and make decisions has to be the data owner. And to do that, central IT can easily facilitate that by products such as ours, where you're going in and saying, hey, set policies centrally, but enable locally. And when you think about that thematically, now you're actually saying every single constituent who is in that ecosystem has a right and a management layer, but within the rules that are set from a central standpoint. And I think when you can put that into enablement, it actually allows a far more flexible and agile capability, because each data owner has their own nuance, view, use, but can only do so within the limitations of organizational rules and regulations.
Dr. Rob, what are your thoughts?
I think Mr. Mehta is a very eloquent person. He is very nicely uh,
I'm
illustrated.
gonna have to send Dr. Rob $20 for that compliment.
No, man, that is true because as you were saying it, I was watching very carefully your words. The thing that we have to understand, we are in our healthcare systems, we have an IT team.
Yeah.
Some places the data team is under somebody else, so the analytics is something else. Then informatics is something else, and then so we're not actually the gatekeeper of data anyway,
Correct.
except we do control the Active Directory, and
Correct.
we do actually control the lake house where you put on top layer where you put the things, and who gets access to what is governed by somebody else.
Correct.
Like, you know what I'm saying? Uh, so I cannot add more to it other than that. I can say that we will always be the enabler. We are the enabler because that's our job. We are a service department. So our job is to make sure that everybody knows and understands that if they ask us for something, we have to go through a policy, we have to go through a procedure, what we are allowed to do and not to do. So as leaders, but we have to, I also have a hat of a leader, we have to plan that so that it's not an IT function. Well, it becomes like a data function. Like when you go to an institution, they assign you a laptop, they assign you certain apps, they assign you things. Same thing, they should just assign you certain data. So it should be that like you use the example of Apple. Like today, uh, what we are trying to do is if I give you a laptop, you just go to your intranet site and download the apps that you need
Correct.
based on the permission that your boss has given to
Correct.
you. So we are working on that. So we have a long way to go, but that's how we become because the moment you use the word gatekeeper for us, it becomes very bad.
Yeah,
So
it
how
has a
do
negative connotation to
yeah,
an
so
IT
we are
guy.
not that. We are not that. We're trying to get away from the blame game. So that's what we are trying to tell people.
I'm going to expand on what Dr. Rob said, because at Renown Health, the IT division and the enterprise data and analytics division are actually completely separate, run by two different leaders. So Chuck Podesta runs IT as the CIO, and I'm running ED&A as the CAO. And I would say IT is definitely not the gatekeepers of data, but you may correctly say ED&A within Renown Health organization does have that role as gatekeeping. So let me take 2 steps back and actually kind of address this question overall. If your health system has disparate data all over the place, and that's their current reality of their reporting, the very first step the company should take is to centralize that data into some kind of modern data warehouse environment and make sure that you have governance around that, which means you understand the data going in there. There is standardized definitions and meanings in there. Because if you don't have that, you really can't execute a good self-service operation, and they won't trust the data, and then they won't use your self-service environment tools or reports you create for them because they don't trust the data. And so that very first step is solve for anything disparate, whether that's disparate data silos or disparate reporting. Number 2 is if a company does not have an analytics and data governance program, that needs to be somewhere in the beginning, is you've got to be able to have a forum where you can also just be able to have conversations around what should the standardized practice be, who should gain access to the data. That's usually another common area within a data analytics, and that's critical when it comes to the PHI, private information identifiers and sensitive data, right? I'm going to talk about internal operations. I'm not even talking about cross-institutional data sharing right now, but I'm just talking about how do you just operationalize this within your own hospital or health system to be able to keep operations moving forward. So solving for disparate data, solving for governance, making sure all that data is in at least one environment, because then that makes it a lot easier for downstream reporting or downstream self-service data access. And then from there, having the appropriate training in place. If you just give tools to everybody, even if they know how to use the tools, it'll start becoming the wild, wild west. And so those are some of the 3 things I would recommend. And we could probably spend another 30 minutes talking about 12 or 20 things in this space, but those will be the top 3 things off the top of mind I'd like to add to the conversation.
All right, excellent. Justin, we're gonna start this section with you. Do you have a question for one or both of your co-panelists?
Yes, I have a question for Dr. Rob. It's something that I'm interested in. We've talked a lot about kind of self-service analytics, and we've kind of talked about that role of how do you provision data and information. So I'm curious, in your organization, how do you handle project and data requests and prioritization?
Yeah, so I'll answer that in two ways. So because when you work in a place and you first implement something, so at our place when we first started our job, we had 28 electronic health records. Did you hear what I said? 28 EHRs, and we had 9 ERP systems. Okay, so I can 180 patient portals.
Oof.
Wow.
In 2 years, we had one EHR, one ERP, and we got to one patient portal, right? To do that, we had to go through all kinds of governance, all kinds of committees, all kinds of people, and all kinds of work, right? So in the world, we have Epic as our EHR, phenomenal EHR works very well. So we're doing it. Implementation is different. Going live is different. 2 years after that, everybody forgot where we came from. That is different. So now it's the optimization part and the project request part. So we had to do governance 2.0. And that means the first governance was to go live. So that's what I'm saying. Like if adaptability, agility, and reinventing yourself are very important. That's why I say I'm lucky I work here because people are open to it. So in that governance, we have an entire flow from top to bottom. 75% of the decisions we expect should be made at the bottom.
Hmm.
That means at the work group level, at the analyst level. So as it goes up to the pyramid, which is the highest level, which is the highest steering committee, less than 3% should come to us. So what it does, what we are working on it, we are still making it better. So don't start publishing that Dr. Rao is the best. Not yet. Okay. So but 6 months from today, I can send Dr. Harvey to talk about it. So what I'm saying is this: by doing that, we eliminated lot of unnecessary burden on the top, because the people who are at the work, who actually do the work, know the most.
Yeah.
And if you don't show respect to that, then you are not genuine. So in that way, they actually prioritize and reprioritize it. And also remember, we don't have infinite dollars also. So there are criteria for it. That is the way we're trying to solve the influx. Of course, one or two things big will come and we'll try to manage the bandwidth or outsource a little bit, talk to two other people, or get an extra person. Or if it's Epic, we get a boost person, whatever we need to do. You know what I'm saying? To manage that. But at least we have a Databricks, we have a Lakehouse, we have a way the ETL goes in, we have an AGI layer on top and a Symantec layer that allows us to have the data in one place so we can do whatever we want with it in a quick way. I hope I answered your question, brother. You are more intelligent than I am. So you already knew the answer.
All right, all right. That was very good, very good. Um, Dr. Rob, do you have a question for or one or both of your brilliant co-panelists?
Well, I think we all know that Justin is a professor. He teaches, he knows a lot. So maybe Mr. Mehta can help us understand. If you want to give me an advice as a CIO, as a CDIO, uh, feel free to direct me and guide me. Same thing from Justin. Give me one advice. What should I be doing?
I
Piyush,
think
it's a pretty general question, but yeah,
it's a
go.
tough question when he just said what he's been able to do in terms of consolidation and optimization. Um, what I would say is, from an advice standpoint, I guess, if you can break the silos within your organization to talk the same language, and to talk at the same data playing field, you will resolve 90% of the issues that go into the siloed approach of how data is managed. Most organizations still run extremely siloed. Justin even mentioned Renown, right? Like CIO will run separately than chief analytics officer. If you're not using the same process to understand the data at a holistic level, I believe you set yourself up for failure because your starting point is different. So how can you come to the same endpoint without having commonality of your starting point? So that's one thing that I would say to everybody is make sure that whatever you're using to analyze and know what your data is and then classify it starts with one central plane across all these acronyms of CIO, CISO, CAO, CDOs, etc.
Justin, any thoughts there? Your piece of advice for Dr. Rob?
I think
Justin?
one
Go
piece
ahead.
of the well, actually, one piece of advice I would be most interested in providing is as you do that technology consolidation, are you also consolidating your analytic and reporting tool? Or have you thought through, or perhaps think through, how you may be consolidating reporting analytic tools at the end user level? So as kind of the top stack of technology and transactional systems start all consolidating down, is that same issue observed in reporting, statistics, analytics, those other tools? And if
Spot
so,
on.
what
Spot
does
on.
that strategy look like as far as
Yeah,
trying to wrap that around?
because what Mr. Mehta said, we are doing in February, 100, more than 100 people are gathering together
Okay.
to do that. And for your answer, I got a little caught up because generative AI has totally changed the way when we used to send Excel sheet and the green report, it doesn't work that way anymore. But people still want a push report. You know what I'm saying?
Right.
People
Yeah.
still want Power BI. People still want
Yes.
those kind of things. And then, but generative AI is totally changing it into an app way. So the advice that you have given me I just validated that. Thank you for doing that. First of all, very grateful for that. To think that way because it actually helps me talk to my team and learn it. We are a very open team. You know, we learn at every level. We are very humble people. It's not that there's nothing to learn, but thank you. Very grateful. Very grateful.
Oh, this is just wonderful to see all this kind of knowledge exchange and joy. Wonderful. All right, we're almost out of time. How I'm going to frame this up is you've just given each other some advice. Let's each offer our best piece of advice for someone listening to the call today who is, let's assume they're not as far along as some of our leaders here. Let's assume they're much earlier in this process. What would be some of the basic starting points, blocking and tackling, however the low-hanging fruit, whatever expression you want to use to describe a good way to get started? Justin, let's start with you.
Yep. Meet with your business users and your clinical users that are your key stakeholders in each area of operations and listen. Practice wait, right? So they start talking, actually wait, listen to their needs, listen to how they use data on a day-to-day basis, what type of tools they use, what tools do they prefer to use, how can you make it, to some of the conversation earlier, make it easier for them to use the current tools or reports or information that they're doing in their day-to-day basis, and listen. So wait, listen, and ask curious questions. That's how I started so that I could understand truly their needs, their worldview, the picture of the organization, and did a lot of that. And I still do that today. That's actually where I start with the business acumen. And then from there, you start, working your way up into the analytic professionals and then collaborating with IT from there. But it really starts with your stakeholders, your business users, your clinical workforce, and understanding their needs and making sure that they know you're there, you're approachable, you're listening to them, and that they feel heard. And that's the best advice I can give for anyone that's either starting a journey or that needs to make a major transformation.
Perfect. Thank you, Justin. Dr. Rob?
Very well said, Justin. To add to that, in my mind, uh, we all don't know everything. So listening is important. And once we have understood something, uh, verify again that you actually what they said is what you understood, because it will help you in your marriage too. You ask your wife, what did you mean by that? So just to let you know. That's the first advice. Second is that there are only three. Second is that you are not the only person who's thinking about it. There are other institutions who are doing it, and there are other people who are doing it. Just talk to them. And the last thing is psychological safety. That means allow, if you are a big leader, allow your people who work for you, with you, they can say things and they can do things without fear of any consequence. Because if you create that environment where people, staff, employees, and friends have a place where they have that safety thing, that we are talking in a very collaborative way. Like sometimes there's a question that can you report a patient safety thing without any fear? Some surveys ask that. That's what I mean. What I mean is that if you are a top leader, allow your people to actually speak their mind, so they have that psychological safety, which will allow a very healing environment to work in.
Perfect, Piyush. We'll give you the last word.
Well, I think these guys have said it well. At the end of the day, you are not alone, as Dr. Rab says. As Justin said, speaking to your internal customers from a data analytics officer or from a CIO or CISO standpoint, and understanding their needs and requirements is also important. And from our standpoint, what I would say is understand that when you're thinking about data, it is important to understand what you have, where it resides, who has access, all the key basic tenets, and start with that before you try to solve the problem. Because you got to know what problem you're solving for. And it takes an understanding of what your starting point is from your repositories before you could start doing a plan of attack. Once you have that, you at least have an understanding of what am I dealing with. And then you have the constituents who are telling you what their expectation is. And know that you have multiple people in terms of other organizations that are facing similar things, and have that conversation.
Well, incredible conversation. It was really very enjoyable, and I think it's going to be a lot of value to a lot of folks. So thank you guys so much. Regarding continuing education, you could use the final slide in this deck. You'll get an email when the on-demand recording of this is ready for viewing. If you want to work with us, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for upcoming panels. With that, I want to thank our tremendous panel, Dr. Shafiq Rab, Justin Coran, and Piyush Mehta in Data Dynamics for sponsoring, and you for attending. And with that, everybody have a wonderful day. Thank you.
Thank you.
Thanks.
Thank you so
Thanks.
much.